Welcome to the Healthcare Nation podcast. Happy today to have as our guest, Emily Evans. Emily is a leading figure in the health sector with many years of professional experience in the area of risk analysis and the markets and policy and how that all comes together for what I would say is giving clients key insights into what's happening in the sector. Currently, she's the managing director of health policy at Hedgeye Risk Management, which is an independent investment research and online media company specializing in really generating comprehensive investment ideas for their clients. She's got a great background, obviously in the private sector with Obsidian Research, which is a boutique healthcare research firm way back. Also JC Bradford, which transitioned to UBS and Payne Weber, but also increasingly, I think one of her areas of expertise being policy. She's got real experience there. She was a 9-year member of the Nashville City Council, which exemplified not only her dedication to public service, but gave her a political insight that I think benefits the folks she works with, her clients, and also is going to help our audience. Hey, for our Healthcare Nation podcast audience, don't forget, if you're watching us on our YouTube channel, please like and subscribe. We appreciate your support. If you have any questions, go to our website, healthcarenationpodcast.com. Then submit those questions for Joe and I to tackle when we do our quarterly wrap-ups. Thank you for being supporters of the Healthcare Nation. So with that, let's welcome Emily Evans.
Welcome to the Healthcare Nation podcast. We're committed to bringing you thought leaders in the field to discuss what's new and noteworthy in the healthcare sector. Now your host, Rick Gannotta.
Okay, so welcome Emily Evans to the Healthcare Nation podcast. Emily, so glad to have you here. I've been wanting to interview you for a while.
Well, you should have called earlier. Thanks, Rick. I'm glad to be here.
Should have, but timing is everything, right? And that's the key. I think given that, there's so much that I want to talk to you about. And I think I gave you a little preview, everything from the markets, private equity, shortages, new models of care, obviously reimbursement, which is a big part of this, and the retail influence that's coming into, I think, the healthcare sector and how that plays out with consumerism. But all that said, let's just jump in. I would love to get your perspective on where we're at with labor, kind of in the aggregate in healthcare. We just got, I think, a jobs report. It showed that healthcare labor had a good report. There were new jobs added. I don't know if that's true when I look at how that translates to bedside clinical positions, let's just say nurses or even the physician side of things. So all that said, what do you think about the shortages, the impending worsening of the shortages, and how that's going to change or influence the sector, particularly on the delivery side? And also, what kind of remedies are we going to look at to address that?
Well, as you know, healthcare is about labor. At the end of the day, at the beginning of the day too, if you don't have a person there bedside or in a doctor's office to deliver care, you don't have much. For all the talk about AI and and digital health and whatever, it's a caregiving business, people to people. That's what it is. And labor shortages, and specifically the cost of labor, peaked about the fourth quarter of 2022 and has been slowly improving throughout 2023 and again with this latest jobs report, 2024. It's doing that in part because the employment opportunities in other parts of the economy have dimmed somewhat because of the, what will probably be defined as maybe not quite a recession in fourth quarter and first quarter of this year, but definitely a slowing of economic growth. So we are in a better place in terms of availability of labor, and we see that both in hires and we see that in wage rates and we see that in hours worked. So the situation is improving. It doesn't address some of the long-term systemic issues like age of the workforce, but for here and now, the situation is generally getting better.
Yeah, when you mention the age side of things, and I think again, let's focus on nursing for a second. The age of the average nurse is up there, pushing 50. Plus, I also think that younger people going into the profession may have a very different notion of where they're going with their career, which does make me think about the model of care. And, I know you mentioned the technology briefly. Is there going to be any play for looking at reimbursement or different models? And I hate to even get into the situation where you tie labor to unions, but I know that big markets that I've been in, New York, Chicago, California, you also have a union element there that you have to deal with when it comes to those sectors.
Yeah, the unions or right now, at least from the latest data, are making more noise than they are actually affecting things. But in nursing, you had you most providers are in a tough spot because nurses get pulled away from the bedside and often prefer as they age to get pulled away to the bedside into the healthcare IT area, for example, into management as another example. However, the training of new nurses has gotten better, and we saw this really not until it virtually stopped in 2021. But we did start to see an improvement in 2022, 23, the number of people taking the nursing exam. The problem with that is that a new nurse and the Sam Hazen, who runs HCA Healthcare, I think will tell you this, is that a new nurse is about 60% productive when compared to a seasoned veteran. So you have and you continue to see, I think, and this has contributed to the slower throughput throughout 2022 and 2023 at hospitals where you simply don't have the expertise you once had. The federal policy has been quite ambitious when it comes to trying to reinforce workforce issues and improve that. I think that is going to and will is bearing fruit at this point.
Yeah, when I think about, I would say the shortage in general and how it does impact care and just your observations on the productivity of new nurses. I do think that the professional life cycle though is getting shorter. What I've seen is that young folks who come in, even I'm talking about physicians as well, they quickly want to transition to an administrative role or something
Yeah.
a little bit more entrepreneurial, which is just hurting us on the back end, particularly when you think about the law of large numbers and where the baby boomers are at right now and the kind of burden that's going to put on our healthcare system.
And the push into, physicians try to push into, the entrepreneurial space. I actually don't, it's not great for supply, but I think it's got this silver lining, which is doctors and nurses look at the way in which we practice healthcare and they want to find better ways of doing that and better solutions. And we do see, and I'm fairly involved with a pre-seed and seed fund here in Nashville called Jumpstart Health Investors. We see at that level people trying to solve big problems. And then at another level, for example, HCA, they're attacking this clinical shortage thing in in the probably the same way Henry Ford looked at the assembly line, although they would really be angry with that kind of a comparison. But looking at things like how much time does a nurse spend doing this particular task versus that particular task? And they've done that work and they have those answers and they are using it to streamline care, but also to make sure that the outcomes are acceptable. Because remember, they get penalized, right? If their
Right.
outcomes are not great. So they have to thread the needle between, all right, how do I automate or at least make like one hospital I know, they have a process for identifying using advanced analytics, some would call AI, identifying somebody who should go into the ICU instead of the kind of anecdotal patient nurse experience. which if it's a young nurse is very limited experience. And getting that person into the ICU before that crisis really hits has resulted in some really important advances in mortality by reducing it. So those are the kinds of things that are happening below the surface that a lot of people can't see, and you certainly can't yet see it in the numbers. But I think you will.
Yeah, I think the early warning systems almost, I called it care traffic control instead of air traffic control.
Yeah,
When
it's a
you're
good
really,
name for it.
identifying folks up front who may be at risk. We saw this a lot in COVID with wearables and the expansion of wearables and even elements of telemedicine into the home, which I think is all great. What stands in the way, I think, of a lot of this on the innovative side is you'll have folks who are, let's just say on the tech side, Silicon Valley, who are fantastic, but they don't have any healthcare perspective and that healthcare
Yeah.
content expertise is not imported. Then the folks who have the great ideas on the healthcare side don't understand how to navigate, whether it's private equity or raising money or just the whole process of ideation to commercialization. You
Yeah.
layer on top of that regulation, and reimbursement, it's a whole new,
Yeah.
world for folks. I'd love to hear your thoughts on that.
Yeah, I think that we've seen the results of this. We saw it first with Theranos,
Mhm.
and Olive is another, you know, big high flying company that has broken up. We're going to see more of that, where you get business people and maybe technology people trying to apply a solution without understanding the workflows, without understanding the 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 duty of the people involved, and without understanding how this will be implemented, and does it deliver something better? Does it do more people survive? Do they have a better experience in the hospital, the healthcare system? And that is clearly been an issue, and I think that it will continue to be an issue, although there's a little less money sloshing around in Silicon Valley these days. But if you take private equity, I'm going to defend it a little bit. By there's a ton of bad practice. A lot of private equity's plan is they buy up a bunch of physicians' practices, roll it up, and then engage in what they call rate lift, which is to increase the reimbursement. Okay, fine. That usually we call them roll up blow ups where I'm from. Is usually how it plays out. But if you look at some of the private equity owned health systems, they are the first to engage in technology advancement. Ardent Health, for example, which is largely private equity owned here in Nashville, they have been spending a lot of time on developing solutions, automated algorithmic solutions on the business side of their hospital. Scheduling is a great example of that. Yeah, and an easy example.
Yeah.
And then and also we've already seen it with, claims submissions. It's sort of the battle of the machines between the big healthcare providers and the big insurance companies. So the private equity guys seem to be more willing to engage in activities that get more productivity out of their workforce and make their workforce happier. They're doing less repetitive things and more interesting things. So that's my defense of private equity. Don't
Yeah,
tell me.
and listen, I'm with you 100%. And we've said it here on the show many times that I've said right or wrong, but it's my opinion that most of the innovation you're seeing now, and certainly for the last number of years, has come out of the private sector. Whereas maybe
That's right.
historically it was, you looked at government and NIH, and now not only is there a trust issue there, but just the innovation that we're seeing. Yeah, I think it's almost analogous to what, SpaceX and NASA. We're really seeing a lot now happening that I think is forward thinking, very, very exciting on the innovation front. And most recently was the acquisition, of a hospital system, essentially, right? With
Yeah.
ADCO and so that is very new territory.
Well, and we are, I think, misled by the regulatory body's enthusiasm for innovation. Like CMMI is a great example. They We've learned a few things, I think, through CMMI programs that have been beneficial. I think some of the work they're doing in the rural health, for example, probably nobody else would do. So there's some benefit. Also, the renal dialysis is another area that probably nobody else would do without them. Although, see, the wonderful companies like Monogram, for example, emerge in that space as well. But the truth that what it took, and we'll see this more clearly in the rearview mirror, but what it took was those labor shortages, and the cost of that labor to suddenly for hospital, particularly the creative ones and the ones with a lot of experience, to say, okay, how am I going to get back to the throughput I had when I'm down 10% of the nurses? And these are kinds of solutions that they've come up with. So it's a weird thing to be thankful for, but that is indeed what happened. And I think it'll continue to bear fruit through time.
Yeah, and I wanted to ask you, I do think that, and you mentioned what I would consider some of the low-hanging fruit with the enormous amounts of paperwork and how companies have come in and addressed that. But how about AI for pre-authorization or, step therapy, those kind of areas where you really can look at that space and perhaps change the velocity of care for what many would consider as low-hanging fruit and not necessarily clinical, but certainly something that is an enormous burden on the sector and the delivery system.
Yeah, and I think you're seeing a lot of that. It's not declared at that, but the pressure, the 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 machinery, the algorithmic submissions of claims are now so sophisticated that to address what concerns might exist for prior authorization, for example, and the insurers, the carriers have their own set of, I call it the fighting machines, up there, which is frustrating policymakers to a great degree, and that's why we've seen a lot of conversation about prior authorization in both Medicaid and Medicare, because there was a system of doing things. That system is changed into a more automated system. A more automated system, it's hard to find humans and make your argument and, all those kinds of things. So I think we are seeing that being expressed somewhat quietly, I would argue, because United Health Group does not want anybody to think that they just have machines
Right.
telling you what they're going to pay for, but that's indeed what they have.
Right. So let me pivot on that, because when I think about, Gen Xers, millennials, comfort with technology, a different type of transactional expectation with respect to a healthcare experience, consumerism, what do you think is happening with the retail sector and the emergence of some significant players, Amazon and obviously Walmart and Target, et cetera, getting it, even Dollar General, getting into this
Yeah.
space? What do you think that is all about? I have my own ideas on that, and we've talked about it for a while, but where's it really going, Emily?
This is, I think, in my category of a little too early to tell, because the healthcare system in most states is so regulated, and particularly in the urbanized, high population states like New York and California, so regulated that what a healthcare provider that's retail focused, let's say like a Walmart, what they can do is a little limited because of, they like Walmart, for example, which has really had trouble getting off of go when it comes to healthcare. But they're looking at the floor and, okay, if I give up 200 square feet for healthcare versus 200 square feet for shoes, which is better? Well, over there in healthcare, you can't do this, you can't do that. Okay, you can do it becomes it's 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 really, I think, made the transition to retail, re- despite the demand. The demand from young people is obviously huge, but it's made it difficult to transfer people to transfer into that environment. you've seen something different in telehealth, where you've seen a very smooth and aggressive transition into that because it meets a lot of the regulatory requirements, and the regulations have been relaxed certainly during COVID, and continue to be advancing as well. I think before retail to really, and what I'm envisioning here is that for most things, not a hospital thing, not cancer treatment or major surgery, but for most things, you'd be able to get your strep test or your pink eye or whatever addressed in a more retail environment. That's going to take, and I think this is inevitable, that's going to take some deregulation. And we've seen this. Kathy McMorris Rogers, the chairman of the House Energy and Commerce Committee, has done some great work on site neutral payments, particularly very small stuff like drug administration. We know that the Trump administration, if it returns, has been very interested in getting rid of the Medicare inpatient only list, for example. So the doc decides where the care is delivered. And deregulation, as we saw in the late 1970s when transportation was deregulated, which of course makes Amazon possible today, ironically, that people will, that deregulation will have to happen, not just to bring the price down, but because people demand it. They want a better experience.
Yeah, and let me comment on that. One is, I think with respect to the retail side, though, would you agree that just the foot traffic coming in, if someone goes in, say to the Minute Clinic or there to get a prescription filled, they're walking out with a bag of items that perhaps the margin on that is 30 to 60%, which would be, good ancillary business, I guess, if you were going to use that strategically.
Yeah, that's the strategy. And we've seen it work well. When it stops working or when it's not been working well is because so much of drug delivery has moved to mail order and specialty. And so to get your medication, in many cases, you just wait for the mail to come. Now, there are a lot of problems with that, which we don't need to get into today, but nonetheless, your number of trips to CVS or Walgreens have dropped, and it's something that they are wrestling with. How do we people are coming to the pharmacy, so what do? Well, we set up these health hubs and these clinics, and that's one strategy. It's been suffering from great execution, though. We're given. I think we're all going to give it more time, but it's a difficult strategy to get themselves away from their legacy approach to this. But I don't disagree with your approach or your analysis. I think that's the future state.
Yeah, let me go back to maybe the political question in a much broader sense and think about regulation. I have thought regulation has been problematic with respect to innovation. And when we talk about, let's just say venture capital, private equity, the private sector, and that being the source of a lot of the innovation that's happening right now. What is going on politically? You mentioned the Trump administration and some of the moves they may make. Can you comment on both parties and what's perhaps going to be top of mind for them when it comes to healthcare delivery, the sector, and regulation?
Well, the Biden approach, I think and this will continue if he is reelected in the fall, has focused on a couple of things. One, the labor force, ensuring that labor force is robust and all the incentives are there to make sure that that labor force is well paid. Mr. Biden, of course, is and as his predecessor or his president when he was vice president, President Obama, they got to the White House in part through union support, and they are keenly aware that they need to keep that support. So that's the first thing. The second part of it is insurance coverage, making sure that there is robust insurance company coverage. I'm sorry, for all levels of society, which on my data achieved and then some. So that's where their focus is, and they've been talking a lot about private equity lately and how bad private equity is, and gets back to their labor question or their labor issue because private equity tends to try and get things to run more efficiently. We can argue whether that's good or bad, but that's what they try and do. The Trump administration had this very chaotic, and I'm probably being kind here, healthcare policy at the beginning of the term, 2016, 2017. Republicans are famous for not actually developing healthcare policy. They've always preferred defense and tax and, those kinds of things. And it definitely showed in 2016, 2017. But when the policy did take hold, the most obvious theme that ran through it was deregulation, ending the inpatient only list for hospitals, for example, which would see the migration of a lot of care into ambulatory surgery centers and physician outpatient and so forth. Their approach to drugs, and particularly the 340B program, which is a drug discount program that helps nonprofits, was very, very similar. So I think where we're, and I don't know of any disagreement they've ever had with private equity or venture capital. So if we have another Biden administration, we are likely to see, more of the same, and the more of the same has some problems, which is right now we are printing a lot of money, and a lot of that money printing is going into the healthcare sector. It's 18% of GDP. As GDP recedes, we could see it pick up another percentage point in the coming years or so. And the only way out of that fiscal issue is going to be deregulation, which I don't think the Biden administration is likely to undertake. So that's kind of where we are. There's a little bit of a standoff. Should Republicans do something with the Affordable Care Act? Some say no, some say yes. But that's how the globe looks to me. My crystal ball looks to me today. I'll reserve the right to amend as we get closer to the election, though.
Let me, on that theme, talk a little bit, if you would, Emily, about Medicare Advantage and also managed Medicaid at the state level, where they're
Yeah.
at now, where they're going with respect to growth, expansion, and how that might change under either administration.
This is an interesting topic. How many times, Rick, do you hear a day, well, America is aging, 10,000 people turn 65 every day, right? How long have you been hearing that?
Yeah.
10 years?
Yeah, constantly.
15 years?
Absolutely. Yeah.
Well, if you look at the Census Bureau population by age, the last of the post-war generation, so is the 1961-62 cohort. They turn 65 in 2020, 27, call it 27. And then from there, the number of people turning 65 declines rapidly until you hit this little bump in this 1971-72 cohort. But it's back to trough after that little bump. And it's 2040 before you actually start to see more growth in the over 65 population. And this is just demographics. It's just a question of when people were born and how they're aging. So as a result of that, and you're seeing the early signs of this, Cigna is selling their Medicare Advantage business. Humana is rumored to be taken over by somebody. You're going to see probably more acquisitions in this space. I think Devoted Health has been having some problems as well. But what will happen here with fewer people aging into Medicare Advantage, it's a knife fight for customers. So you have to offer the best premium, lowest possible premium, the highest possible benefits. And that's the kind of thing you could do if you've got a lot of capital, like your United Health Group or Humana or Elevance. Probably not so much if you're a Devoted Health or even if you're a small Blue Cross Blue Shield plan. So we're going to see a lot of consolidation there. We're also going to see a lot of penetration, increased penetration. My estimate of total penetration in Medicare Advantage just a few years ago was around 50%. Because getting into these rural markets, I mean, you run a hospital and and someone says, "Hey, do you want to be in our Medicare Advantage plan network?" No, because you're the only hospital in the state or in the county or whatever. That penetration is actually getting a huge boost from the redesign of Medicare Part D that was part of the Inflation Reduction Act. Now, all the incentives are to have a Medicare Part D drug benefit paired with a Medicare Advantage plan. The very common pairing traditional Medicare, with a standalone PDP plan, that is much less interesting in the plan for the plans. And we're going to see, I think, a decline. We still see and are seeing a decline in that membership, which is not necessarily going to force up the membership in Medicare Advantage, which is going to cause a lot of heartburn on Capitol Hill because there's a fairly substantial group on both sides of the Hill that see Medicare Advantage as privatization, and they are not for that.
Right. But let me ask
So
you one thing. How does lifespan factor into this when you look at not only longevity, but also acuity that particular population and what that would mean for an MA plan if you were just thinking about it actuarially?
yeah, if you think about it actuarially, your highest cost years as a senior are age 72 to 78, right? Is that fair?
I
I
think,
mean,
yeah,
I've
yeah.
seen different studies, but does that seem fair? All right, so the 1947 cohort, which is the biggest birth cohort in the United States, turned 65 in 2012. So they are today, 70? This is 2023, so they are 76, 77, depending on what year they're born, right? If my math's right there. They are in the bullseye of the high acuity years. So the pressure on medical loss ratios for the insurance carriers is high. And it's going to, I expect it to be higher in 23. It looks like it all kind of accumulated in the fourth quarter, judging on, reports from Humana, for example. I think it's going to continue in 2024. We're going to see high acuity as that group starts to clear their highest utilization and most expensive years in terms of cancer and neurologic neurodegenerative diseases and cardiac diseases.
And Emily,
So
that would be part of, I think, the washing out of the smaller players and the consolidation you're
yes,
seeing, right? I mean, that would
yes,
go into that. Just makes sense. Which, I mean, I'm not saying this is the case, but yeah, I do think on Capitol Hill there is a lot of folks who are saying, sure, this is the way out. MA plans, privatization, and it does put a line in the sand. There's no doubt about it. But like you, I do not see them going away at all. What's
no,
going to
no.
happen though at the state level with Medicaid and management?
Medicaid is so interesting. Before the public health emergency was declared in March of 2020, there are about 64 million people on Medicaid, managed care, fee for service, all kinds of configurations, including expansion, non-expansion. There are about 7 million kids in the CHIP program. Today, we have about 82 million people on Medicaid and about 7 million kids in the CHIP program. So we're 17 million people long, as we say in my business. We have 17 million more people in Medicaid than we had prior to the public health emergency. And at the same time, you have certain states who are claiming that they are almost done. We've finished that process. We've disenrolled a lot of people. And the budget question that will be asked is, how come there's so many more people on this program than there were in March of 2020? Now, part of the answer to that is that in some states, and this has been a thorn in the side of the oversight people, some states will take what is a traditional Medicaid beneficiary, aged, blind, disabled, pregnant woman, and push them into the expansion population because they get a 90% match instead of a 50% match. We know that that is part of what is going on. There's also probably a lot of duplicate enrollment, people in Medicaid, but also in exchange plans, but also insured by their employers. But what has happened, because back to what I was saying about the Biden White House, is it's very important to them to maintain coverage because they, for political reasons, do not want to face an uninsured rate that goes up. They are very committed to the Affordable Care Act. Many of them are, most of the White House are former, Obama people. And so they have been very deferential to activists like the Georgetown Center for Families and Children, who have been very outspoken about any disenrollment whatsoever. And our model has about 253 million people insured when you add up Medicare, Medicaid, ACA plan, whatever. There's about 260 million people. That's about as close as one can get to universal coverage. But there's a deference to the coverage advocacy system by the White House that means they're not really pushing very hard on disenrolling. You see states like Florida being more aggressive, getting a lot of heat from the CMS, and actually filed suit last week over it. And that's the push and pull, the tension, if you will, between the states and the regulators that is not likely to go away before January of 2025.
What happens?
It may never go away.
Then what happens under a Trump administration with Medicaid?
Trump administration, Seema Verma, as I'm sure everybody knows, was
just your picture to Oracle Health now, right? Yeah.
She has gone to Oracle Health, but her background was in Indiana. She worked for Mike Pence, and she developed a number of Medicaid reforms. And Indiana has some interesting programs pairing, giving people essentially an HRA that they can, manage, and as in addition to Medicaid, training them, if you will, to be health insurance consumers in the private market, which if you're on a Medicaid plan, you're not necessarily going to be a good health insurance consumer. So Seema Verma's attitude towards Medicaid throughout the term, while she was there, 2016, 2020, was great deference to the states. What do you want to try? How do you want to make this work? And one of the policies that Congress passed that she championed was the individual HRA, where an employer can say to his employees, we're not going to offer health insurance because they don't have to under the law. We're not going to offer health insurance, but here's $200 a month. Go spend that on the ACA exchanges, and you will get we will get all the tax benefits that we get with an HRA. You will get to pick what you want. You don't have to pick what I pick. Those kinds of things. So it's kind of it's a part of that deregulation attitude that the Trump administration has, but also a deference to states that she feels are in a better position to come up with innovation. And there's isolated circumstances. She didn't get to do it very long, but there are isolated circumstances that suggest that she was probably right about that.
Yeah, when I think about just self-insured plans that are out there, employers self-insured, in companies that are there, and how the pandemic kind of influenced the playing field with respect to all things insurance, exchanges, et cetera. Do you have any observations on that space?
On the ACA marketplace
Yeah,
insurance
on the
exchanges?
marketplace. Yeah.
Yeah, well, they got a big boost, and this is why enrollment is at 20 million. It's still behind the original estimates, but now it's getting closer. But a couple of things changed during the public health emergency. One of those was the threshold for eligibility, the upper bound of that threshold was people making 400% or more of the federal poverty level. You weren't eligible to get any of the subsidies on the exchange. That was lifted through 2025, the end of 2025. The other change was the end, and was an administrative change, it didn't involve Congress, was the end of the family glitch. And not to get into it in detail, but it essentially discouraged entire families from signing up for ACA exchanges if one member of the family had a job. That has been fixed as well. So the combination of these two things have really accelerated the enrollment in the ACA exchanges, and I think presents a really interesting issue, which back to what I was saying about Medicaid enrollment. If you look at Texas, for example, their ACA enrollment population, about 60% of it would be Medicaid eligible if they expanded Medicaid. And which, if you're a provider in Texas, what do you want? You
Yeah.
want people to stay on the ACA exchanges, right? You don't want Medicaid expansion.
No, absolutely. Yeah.
Yeah, and then let's say you're a state that was very enthusiastic about expanding Medicaid, and a new governor comes in, and he's got a budget problem. He starts looking at what's going on in Florida and thinking, "Well, I mean, these people are insured,
Yeah.
you know, and it doesn't have anything to do with my budget. So what's wrong with doing that?" And that's going to present a real issue, I think, for that universe that believes firmly that Medicaid is the way to go. Medicaid, as we know, and has a number of shortcomings. It has a lot of shortcomings as far as a health plan goes, and it's not the perfect thing that people think it is.
Yeah. And
They encountered it.
before we leave this particular topic and section, any observation on what's happening with the venture capital in the Medicaid space and the managed Medicaid space?
I have seen mostly point type solutions for managed Medicaid to address particularly problems in the behavioral health space. That's been a focus. Also, intellectually and developmentally disabled populations have seen a lot of interesting things go on there. I haven't seen too terribly much. One of the interesting things about Medicaid is a lot of it is children, not just in the CHIP program, but also, the babies as well. And they don't require a lot of care. Children are high healthcare utilizers. One area that is just taking off is maternal health and
A lot in
trying to
there.
solve for that problem of, why are so many women dying? Why are their babies dying? And being very aggressive. And I think to the credit of many states, including Republican states that have not expanded Medicaid, it's been nearly universal that to expand the postpartum coverage to a year or more in some cases to look at that. And I've seen some solutions developing to address that problem.
So let me switch completely. Maybe it's one of your favorite topics. I don't know, but let's talk about pharma. I think I could probably spend an entire podcast with you on this. But I really wanted to get your perspectives on, how is the pharmaceutical industry addressing this balance between innovation access, regulation, and also navigating, I think I could say, controversies around things like the GLP-1s and how that's all kind of coming down.
The whole thinking back in the 90s when China was admitted to the World Trade Organization and NAFTA was inked, the thinking was, America would be the brains, right? And the rest of the world would be the brawn. They would do the environment. They would make paint, for example, which we can now get again. I don't know where they're making it, but they would make paint and they would do nasty, smelly things that we didn't want in our country. I'm being a little hyperbolic, but that's what happened. And and we would be the brains. And one of the a keystone to that strategy was pharma. Uh, And where pharma has found itself, unfortunately, because of its opaqueness, it tries very hard to protect its intellectual property. Nobody argues with that. Unfortunately, their customers are governments, which don't like that sort of thing. They have also found themselves as one of the only unregulated parts in terms of price in the healthcare system. So if you're a hospital, your price is regulated by other insurance companies or the government. Same with a doctor, et cetera. Back to that whole regulation problem. So what happened? What happened was everybody started exploiting the drug channel as best they could because those guys could raise their prices to the roof, and they did. And everybody would take a little piece out of that drug channel. And yes, I am simplifying things. The setup for them was just eye-popping prices that got the attention of the public. They weren't real. Those prices weren't real. But because the system was so opaque, they couldn't explain that to anybody. So they ended up with this Inflation Reduction Act, which does two things, the most important of which it keys Medicare prices to inflation, just like Medicaid already does. And it sets up a negotiation process for 10 drugs beginning this September. I suspect that negotiation process will be tossed out because the penalty for not negotiating is initially a 65% excise tax, which rises to 95% over several years, which I don't think the courts are going to look at that as a tax. I think they're going to look at it as a taking because it is so big. But that remains to be seen. But while we've been rolling along through this process and pharma's been under this pressure from everybody who wants, in on their drug channel, they haven't been doing a ton of innovation. They've been buying most of their innovation from biotech, which is fueled by federal dollars. That money is drying up. There's less things go. And they haven't been for years, looking, with the exception of a company like, there are, Regeneron is very outspoken about this. They haven't really come up with great solutions. And some of the oncology drugs, for example, a hefty percentage of them are worse than the disease itself,
Yeah.
as a lot of people will complain. So this is where they find themselves, and I think there really is going to have to be, and we've seen early signs of this from Santa Fe. I think really going to have a moment of clarity about what they're doing and how they're going to do it going forward. I think that inevitably means the industry is going to get smaller. Their solutions are going to be more targeted, and there will probably be less drug ads on television on Sunday night.
Back to the future. Emily, how about payment models for expensive therapies? Are we going to see anything that's going to be outcome-based, the warranty side, subscription models? What are your thoughts on that in that space and where it's going?
You're most likely to see that coming out of Medicaid. I think you might see some of that coming out of Medicare as well, now that we have that inflation cap. We're a few years away from that, I think. But Medicaid has done, I think, some of the best thinking there, the Medicaid directors. This was particularly true on the hepatitis drugs, which we fixed hepatitis, and boy, if you'd had an outcomes-based payment model, you could have, you could have changed the trajectory of some of these companies. But
Absolutely.
uh,
Yeah.
yeah, and I think this is the Alzheimer's drugs might be ripe for that sort of thing, but it's difficult. For the pharmaceutical industry is under a lot of pressure, and they have not been great about negotiating with some of these outcome-based things, in part because they believe that any drug that they make has to be covered by Medicaid and Medicare, and so why bother? There are lots of Medicaid directors who say that's not true. They haven't challenged it officially, but I think we're still a good ways away from that, and I don't see much progress as we find ourselves, or they find themselves in this really tight spot for the next few years.
So more to come on that. Let's wrap up the show with this. I'm going to take advantage of you by saying, look, put you on the hot seat for some predictions moving forward. Really just started
I love
2024.
predictions. I love
Yeah.
predictions.
Well, tell
Get my
us, well, give us your crystal ball out. What's the tailwinds? What are we looking at, Emily, moving forward?
What's my time horizon here?
Yeah. The next year.
Okay,
The
so
remaining 24 into 25.
I would say that healthcare is going to be in a unprecedented, almost unprecedented tailwind. We have almost unprecedented tailwinds. One, utilization, and I'm talking about services right now. Utilization is high and rising just because of the population dynamics of the post-war group. The need for the Washington to keep feeding that beast through a sort of stealth kind of stimulus to protect from job losses is very real and will continue throughout this year. The employment cost index, which dictates a lot of the payment updates for the specific silos in Medicare, that is signaling that we're going to see pretty solid reimbursement. People are older, people are sicker. It's going to be quite the year, is my guess. Uh, uh, uh,
Plus the elections.
and plus the elections. I mean, the healthcare is untouchable,
Right.
as we get into elections. The managed care organizations have gotten a bit of a bad rap because of Humana, their disclosure on a high benefit ratio. I think that gets fixed somewhat with price in 2024. And I think that their premium, the years of the zero premiums are probably over. They're not going to be hundreds of dollars, but they're probably over. And also, at a lot of these managed care organizations, stashed on their balance sheet a lot of money during COVID when they weren't delivering care. They weren't paying for care. So got a lot of financial flexibility that in normal circumstances they would not have, and they would not have as a result of public health emergency. So we have this very unusual period where we have a lot of demand and cost on the services side. We happen to have a lot of money on the payer side too to handle it. So it doesn't come around very often. I think the last time was probably right after passage of the Affordable Care Act, and that was a little bit offset by some Medicare cuts, but we're in a very sweet spot. The one caveat is how this all shapes up for the pharmaceutical industry, which we're going to have to see some court cases before we can make any judgments there.
How about the VC and PE space?
I think the VC and PE space are going to respond. If you are a payer, for example, you have actuaries, you know what's going on, and you know what 2027 and beyond looks like, and as part of grabbing market share, if you're a Medicare Advantage plan, to give you one example, you have to deliver a high quality experience for your plan members, and you have to keep your star ratings up so that you get your bonuses. And what you will see is an effort to do that, whether that's through, you know, more timely and more careful drug, delivery, mail order delivery, or that's through some other mechanism. I think that those kinds of things are gonna get funded. On the provider side, you're still working with less people than you need right now. We see that through job openings, and you're also paying them more than you did in 2019. So you're motivated towards these types of solutions that enhance how many hours in the day that somebody works and how much productivity that they get out of their workforce. Remember, healthcare is not productive. It has very little technological innovation. We talk about how great the technology, but none of it has been directed towards employment. And you're gonna see some of those, and those things are gonna come out of primarily the venture space. And I think it's somewhat got its head screwed on a little bit better after some big hits from 20 and 21. So I think we're gonna see it improve. The setup is pretty remarkable, actually. In that I've not seen anything like this in 25 years.
That sounds, I'll tell you, I think a lot of folks, our listeners are going to be hanging on to that, Emily,
Hey,
and we're going
uh
to have you back for an update on,
can I add one caveat, please? If you are
please.
running a small, mid-size regional hospital, you really need to get your act together in terms of innovation, in terms of, getting your workforce and your workflows optimized. This is not 2019.
Do they get acquired?
They get acquired, or they get shut down. We're seeing the Steward Health in Boston, for example.
Mhm.
There's other reasons for their problems, but we're definitely gonna see some consolidation, and we might see some closures, but a lot of those closures are gonna be because senior leaders have not looked at their problems, for example, labor shortages and higher cost of labor, and gone, "Okay, how do I make each of these people get the most out of the workday?" You know, and that's because 'cause they've never had to. And now they do, and if they don't, then they'll be left behind.
Great insight from Emily Evans. Emily, thank you so much for being on the show. I'm going to have you back. Should have done this a while ago. I think there's going to be a regular spot for us to hit some really important topics moving forward. So on behalf of
Happy
our audience, our listeners, thank you so much. Really appreciate it.
Oh, I'm so glad to have spent this part of my day with you, so looking forward to seeing you again.
We'll do it again. Okay. Thank you everyone for tuning into the Healthcare Nation podcast.
The opinions expressed by the host and guests are for informational purposes only and not associated with any companies or academic institutions. Please follow us wherever you listen to your podcasts, as well as our YouTube channel, Healthcare Nation Podcast. And if you have any questions or want to contact us, please reach out to healthcarenationpodcast.com.